Hi, Matthew Holt, and it is THCB Gang, episode 55, May the 20th. And this is a super exclusive gang because it's just me and Ian. Ian Morrison, Health Futurists. So we're going to have a fun chat about the state of play kind of across the world and what we're thinking about. So that's what we're going to do today. We had a series of other folks lined up for the gang, and for a bunch of reasons, numerous people that drop out. That's usually everyone pretends there's someone else being there, but today it all happened at once. So with that, Ian, welcome. Thanks for being the person who hung out the most.
Thanks, lad. No, it's always a pleasure to chat. So I mean, it's like the old days. We just sit and riff.
Absolutely.
Yeah.
Well, I thought that's kind of, I'd love to do that a little bit, right? Because a lot of people, obviously we have a history and we should talk a bit about that, because way back when, 1993, when you were wandering around the world talking to every drug company, hospital group and health plan and God knows what, I was recruited in theoretically, I think, to do some of the work that you didn't want to do. I'm not sure I did any of that. I went off and did some other stuff, but
we're brought in to strengthen the team, Matthew. That's so you were an essential asset.
So I mean, I'd love to just spend a bit of time chatting about, what the changes that you've seen. So to those people who don't know you particularly well, you spent, obviously, anyone can tell you grew up in Glasgow, but you spent a decent amount of time doing your PhD working in Canada under a very smart guy called Bob Evans, and then came down to the States. Can you, and then, you were at the Institute, I think, Institute for the Future from the mid-'80s, I believe. I can't remember.
Yeah, 85, I joined.
Yeah. Can you tell me a bit about, just to go back to those days, when you were doing your PhD, which you keep on telling me is an urban geographer. You keep on I always tell your story about Kristalla's Central Place theory is the only.
Yeah, exactly.
I never met another geographer, so I don't know if there actually was a guy called Kristalla.
Right? No, it was Walter Kristalla. Yeah, no, he's a wacky German who figured out there's only so far you'd go to buy hay. So, and it sort of explains everything about everything, and then it's easy to remember, and you don't have to really know anything else to be an urban geographer. But anyway,
that's fun. So how did you end up getting from being an urban geographer to being to being ending up in a futures forecasting think tank in California?
It was weird, right? So I was a graduate of Edinburgh University, did geography, did urban planning postgraduate degree in Newcastle, left the UK to go to Canada because I had family members. My father had died actually too, and that was the other thing. I was emigrating, so starting a new life, and ended up, on the shores of British Columbia, and I had family and stuff and a little bit of money I'd been given, but I needed a job, and I ended up getting a job with Management Engineering Unit 13.1. Which was the Canadian healthcare equivalent of the KGB, so it was like, basically they couldn't afford real consultants, so they had an internal group, and it was really interesting because all, our clients basically, and they hired me because they were building hospitals like crazy in BC in the late 70s when I was there, because they had money coming out their ears from selling resources to the Japanese, right? So BC was rocking and rolling. And they didn't need planners. They needed people in the hospital planning business. So anyway, I ended up working there, and then got seconded to work in a department of pathology. My boss was a sort of head of pathology at all of the teaching hospitals and ran a big academic department. And so I was kind of his research flunky, and then coincidentally, his brother was a professor of geography. So they put together this interdisciplinary PhD program. And so my committee was a geography major, a geography professor, a business school professor, Bob Evans, arguably the world's greatest health economist, and a pathologist. So it was kind of a wacky thing. And and coincidentally, it's a bit like I stumbled across you. The Institute stumbled across me because a guy I was working with was working with. We did a little joint project with the institute with the guy John Tideman,
Right.
who was there, and that's really how it happened. He got a grant. He went off to Europe to work for Rupert Murdoch setting up satellites, and they had no one really to work in the grants. So I got hired by the Institute for the Future, and and then that begat Matthew Holt, and Matthew Holt, ran the universe. So
Well, that's
that's the connection. Yeah.
But you did. That's interesting. So then you moved down to the US. So you have the great line, which I don't use, but you should use, about the difference between Scotland, Canada, and California.
Oh,
so you should say it now.
Yeah. Well, I mean, it's the oldest joke I wrote, actually. I'm a Scottish Canadian Californian, which is sort of gives me unique perspective on all things to do with healthcare, including death and dying, because the Scots see death as imminent, Canadians see death as inevitable, and Californians see death as optional, actually. So it's true.
It's
and
true.
Alan Enthoven, your old mentor, it was the only line he ever remember I wrote, and actually, I have an idea, Matthew. I should write it up for the THCB, blog. Is my 20 oldest jokes and why they still matter.
Well,
that's one of them.
It's like you always told me, though. If you're futurist, you don't need to change your slides, because it's
no kidding.
Yeah. No, and I think that was what when I first met you, was you came to Stanford and gave a talk at one of the Health Service Research lectures, and that was like. And I remember like the intense sort of scrutiny of every little thing in academia about, well, did we spend the money right here? Did we do this right there? Or whatever. And you gave it was, I don't, you probably don't remember what it was, but I do. It was it was one of the polls comparing what Canadians thought was what Americans thought about their healthcare system as a whole. It was one of the Harris polls from the early 90s. And that was to me, that was the thing where I looked at you and you were basically saying, if you get out of all the sort of the minutia about, how long were you really waiting for an MRI, or what was the cure of this, and what was the actual, quality rate on the most extreme cancer, which is the stuff that people tend to study in academia about. If you got out all the minutia, you looked at it, most Canadians were reasonably happy and reasonably satisfied with what they had.
Right.
and poor Canadians weren't left out to the way that most Americans were kind of semi-grumpy about what they had, which maybe the death and mortality, and the poor people were treated very badly.
Right.
And if you go, so now, and I think if you and you kind of, when you did the first looking ahead at American healthcare, which is what
87,
88, something like that, right? Which I was one of the main authors of the updated version as you were on your way out of the institute in 98, 97, 98. The same thing is true, right? Now, I know we had the ACA, we've had Stranglodome, we had, the business I'm in now of $1 gazillion being put into new technology, trying to do stuff. But we're still kind of where we are, right? We're now saying, can we get around a lot of this stuff? Can we do different things by doing social determinants of health? And can we use technology with that? We've talked about that in the game. But I don't really see a massive policy or sort of cultural difference in how we're treating healthcare since I started, and I assume since you started. Is that fair?
Yeah, no, I think that's right on. I mean, well, you use my line about you never have to change your slides, but I mean, I'm still stuck with the same analysis. In fact, I was one of the things I was going to, I didn't put this as a prop, but this is, I don't know if you ever saw this. Was when Bob retired, the Morris Bear and the boys put together a kind of collection of all of this, great work,
right?
Which is kind of the Bible, which sits literally in my office. And I've been struck. I read Vince Kuraitis's piece. And we've been having a ongoing debate in this forum and on Clubhouse yesterday about sort of the digital health thing. And I spent a good part of the morning looking at the Judiciary Committee's hearing yesterday. Did you see that?
Oh, this is the one about hospital
crisis. Yeah.
I'd love you. Actually, I don't know if you have time to say a bit more about it. I only read that they had a patient from Pittsburgh who basically said that she had cancer she has shared something that I have a little bit of, which is much worse than I have, which was she had cancer, but they thought she had trigeminal neuralgia, which is the thing on the left side of your face that hurts like when you get it. I get it a little bit. I found out that now the magic mushroom is apparently the cure, so I'm not quite excited about it getting worse, so I can now get some psilocybin. But I only read it, but basically what she was saying was that when UPMC in Pittsburgh got in that massive fight with Highmark and Allegheny, she couldn't get access to the right people at Pittsburgh, Ioneer, or whatever the right group. So, and she felt that meant that her cancer wasn't caught. And I assume, I didn't see it, but by looking at the tone of her remarks, that she was, she said something had a death sentence from that. So I don't know if that's the case.
Well, and then she was on video and she had, lost one ear and was disfigured on one side of her face, but it was tragic. But I must say, I watched I watched the video of the introductions and skimmed much of the testimony. And it's funny, it's coincidental that we're talking about Bob Evans, because what was going through my head is, it's a bit like, what would Jesus think? It's what would Bob Evans interpret this? And who was on was your friend Michael Cannon, who was sort of more Cato Institute liberal. We don't have enough markets going on. Marty Gaynor, being the authoritative, the data all shows it's ugly and bad. And he's not wrong in that. And this is the debate Jeff and I have been sort of stimulating. We don't disagree that that's the net result. The question is, what do you do about it? And then Rod Hochman was on both as head of Providence and chair of the HA board, with the typical defensive integration, not dissimilar to the piece that Jeff and I worked on. And then a guy from the SEIU saying, we've got to protect workers who get abused by this consolidation. And then a doctor who seemed to me from Hawkins, who policy person who was sort of advocating for, we should have, doctor-owned hospitals and more supply. And I was listening to this with the lens of Bob Evans in my head going, you're all full of it. Every single one of you is wrong. First of all, what market? There is no evidence I can see that there's any real price competition going on in hospitals. Hospitals compete like crazy for patients, but it's not on the basis of price. It's on the basis of reputation and prestige, and they do capture doctors, that's for sure, right, to influence deal flow, and some of that's pretty egregious, but it's nothing resembling a market as far as I can make out. And Bob would also say when you're talking about this stuff that the principle that you have to be mindful of is supplier-induced demand, right? And that if you really ask the question, what differentiates us from other countries? Why do we spend 7% of GNP more? It's because we don't have monopsony. We have weak purchasing. And that I think that it's, people like to beat up in the health plans, but you look at those states where the prices are lower, relatively speaking, and the spread, according to the RAND data, it's places where you've got powerful nonprofit blues plans in particular with high market share who have managed to keep the spread relatively tight. Pennsylvania, Arkansas, Iowa, and a lot of them have contracts which are sort of all payer contracts that keep the lid on the thing. So I don't know. I maybe I'm getting too old and cranky, but I think it's all this ideological warfare around we don't have enough of a market and we need to do this, that, and the next thing. And the same applies to digital health. I'm really worried that this is just another layer of, rentiers who are coming in to get their share of and stimulate demand.
So if you went back to 1992, 93, 94, when was it Tom Elkin at CalPERS was wandering around and sort of fighting with fighting with the plans, and the plans went around and started beating up on the providers. And for a while there, hospitals were losing money. And I remember we were looking at that institute back at the time, and everyone was talking about, well, maybe Mulliken is the future. We're going to hand off risk, and they're going to and these medical groups are going to come after, it's capitated medical groups are going to come after the hospitals. The hospital will have to downsize. We have too many specialists. All the reasons we spend too much money. We have too many specialists. We spend too much money on the specialists. Right. Their prices are too high. All that stuff. That'll be sorted out by aggressive buyers. Do you think? Were you surprised that 10 years later that seems to all have gone away, and that the hospitals started consolidating? I mean, I know you were. In some of the hospitals you were advising, you were saying if you want to stay alive, ally with the guy down the street. But we were surprised at sort of how ineffectual purchases ended up being.
Yeah, a little bit. I mean, ironically, I was on a board call at MLK with Bob Margolis yesterday, and we were sort of reflecting back on a number of things. But that when you joined,
Margolis, by the way, for the listeners, was head of health partners in Los Angeles, the big medical group in Los Angeles, which then got bought by DaVita and is now part of Optum. Because
right, and
everyone ended up being part of United at some point, right?
But you and I tromped down to Southern California a lot in the early 90s and got to know the at-risk medical groups. And as you know, I still am a big fan of Bob's and all of those guys. What I had hoped we would see, and to some extent, the current digital health movement is trying to emulate that. I would say the positive spin on what may be happening with this virtual digital care is Margolis 2.0 kind of thing. And that's a good thing. But it's dependent, as Bob was pointing out to me yesterday, on having a sufficient number of hospital choices and specialists and who are willing and able and free to contract with, right? So that you can use your primary care power to sort of get a better deal. But if everybody's locked up in a big system, that model becomes much, much more difficult. And to answer your question directly, yeah, I was a bit surprised. And it was partly because the plans, there was the managed care backlash, right? And that kind of undermined the power of the HMO movement and the delegated capitated movement. And that the backlash ironically led to the rise of PPOs and the rise of open network as the key thing. And then we're away to the races then on the commercial price increases. So, I mean, it was almost there was a moment of opportunity where we were getting towards virtual integration. And if Jeff was on, he would, he was advising a lot of people. He was one of the first people to talk about, virtual Kaisers and those kind of models. And I think both of us were advising people at various points. But when the whole managed care open network thing broke down, that's when some of us sort of pivoted to saying, well, so let's see if hospitals can pull this off. Because I was always struck about how amazing it was that Bob Margolis built what he built, given the culture of medicine, right? And that where were you going to do a similar thing in Houston or Miami or whatever, and it's proven difficult to do.
Yeah, and I remember going around. I was in a project which I think Robert Medman sold to one of the drug companies, I was wandering around interviewing doctors and sort of trying to explain the Mulliken model to them. And there was one guy in Dallas who said, "Yeah, I get it. I'm going to do this in Dallas." And I found out later that they went bankrupt even quicker than everyone else. Yeah. I remember sitting in a room in Chicago and in Miami with all these doctors going, "That sounds bloody awful." I'm not doing that. I'm not working with this guy next to me. And I'm doing I'm doing fine doing independent fee for service. And if that stuff comes to town, maybe. And the joke is, right, 30 years later, 20 nearly 30 years later, it hasn't come to town anywhere, right? In terms of the preponderance of non-fee for service is still pretty low.
Right.
And everyone's working on this and saying, well, let's build a platform, let's build a system whether it's virtual or real, or as Bob Kocher was writing in TechCrunch the other day with Jenny Schneider, let's do a bricks and clicks model where we think it's about 80% virtual, 20% real visits, and they're all trying to figure this out. And as he said, there's a ton of money being thrown at it at the moment, but no one's really figured out how do you change that payment model. Now, I wonder.
There are pockets,
sure.
You know them better than I do. I mean, the Oak Streets and others, who, the private equity backed guys who are saying, I need a captive delivery model and I need a patient flow and I need full risk, blah, blah, blah. And it's certainly what Optum is trying to do with a good chunk of its business. But yeah, you're right. I mean, it's still, I mean, if Jeff was on, he would say, you know, we're underwhelming in terms of the penetration of capitation.
Absolutely.
And part of this, to be honest, what I'm hearing from people like Don Crane, you know, APG, American Physician Groups, is that he has a lot of members who are willing and eager to take risk, but that the plans are not willing to delegate it to them. And I suspect it's because everyone's trying to monetize the muda, as I would put it, you know, which is muda being waste, you know, that they believe, the plans believe they've got the tools to do it, and they don't need at-risk doctors to reform themselves.
Well, I guess the bigger question, or the sort of the big question is, if you go back to the mid-90s, right? I remember Cal was it called Cal Pacific at the time? Cal Pacific Medical Center now, which is right now the shining financial jewel in Sutter's crown in San Francisco. At that point, it was hemorrhaging money, right? And you could, you know, they ended up joining with a bunch of other San Francisco hospitals, eventually, you know, ran to Sutter and sort of got in this big group together. And then we're able to, as we know years later, we're able to basically start going back to the health plans and eventually employers for more money, and righted their financial ship by basically jacking up their prices, as we know Sutter's done for all these years, and everyone else followed them. And then if you added onto that, right, the same time Aetna, right, had just bought US Healthcare and was making big noises about getting into managed care and really doing, you know, trying to say, can we do a virtual Kaiser and all that kind of stuff. And that was a sort of financial disaster. And they, when Jack Rowe got in there in the early 2000s, I remember seeing an article about it. They basically went back to old world insurance. Let's figure out who the healthy groups are. Let's give them a decent price. Anybody who's a sick group, you know, it looks like they may be difficult, we'll ramp up their prices, and they can go away and get insured by somebody else. And they cut their number of lives significantly, and it went from being losing a ton of money to being very profitable, which is, you know, good old risk selection. And right. That, if you look at the way that Medicare Advantage has changed now with the, you know, the risk adjustment factors and all the conversation back and forth about, are they cheating on that and this and the other? It's the same idea, right? If you can figure out how much people are going to cost starting off on the way in, you don't have to do too much to manage them on the way out. And I think there's still a lot of that going on, which is why, to some extent, all the great conversation about having, you know, really great data and having up to the minute sort of data from people who've got chronic illness doesn't matter so much if you kind of figure that out on the way in. I'm not sure how well people are doing that figuring out. It seems to me that there's still a lot of that going on until we can figure out a way policy-wise to really get rid of that. I don't know if there's as much incentives to do this kind of the great care management we've talked about all these years. I don't know. Maybe I'm getting old and cranky too.
No, I agree with that. I mean, I've always believed that it's easier to dodge risk than manage care. You know, sure. You know, I think there's still continuing evidence of that. I mean, the exception being the kind of upcoding frenzy that we're in right now that we've talked about in the gang before, of
right.
The game becoming sort of a jockeying on revenue cycle and how good you are at optimizing, you know, the humans in front of you in terms of what they're. I always keep reminding the great Uwe Reinhardt's, you know, description of people as premium yielding biological structures, and it's sort of like, you know, patients are revenue yielding biological structures. So it's there's still a good deal of that going on, to be sure.
So let's talk a bit about Vince's piece he wrote with Seth Joseph on the book the other day, which I you know, and I think it's kind of you know, every time Vince is on it, pretty could be on it today. He was kind of cry off late, but you know, he is always the optimist, saying, you know, it's going to change. Back in the day, I'll recall, you know, back in the day, 15 to 20 years ago, when I first met with Vince Lott, he was going around a lot talking about, well, what would the impact if Google really got into healthcare, or you know, these other platforms really got in. And he was reading a lot of the tea leaves around that before they even had an announced plan. And that was sort of when Google and Microsoft first got into this and started trying to get into personal health records and whatever else. But, you know, what is his and Seth's basic underlying idea is that, you know, you've got a virtual care platform that is going to start looking like, to integrate all these different things that looks a bit like when the smartphone integrated, phone books and watches and digital assistants and keys and what everything that now lives, the software in the world part lives in that. And his sense is that the if you believe that there is a virtual care platform, which I assume will have some ongoing physical components. We talked about a bit about this in Clubhouse last night, right? You can't, as he said, if you're going to do a biopsy, you've got to have the person in a physical place where you're doing the biopsy. But if you have that, right, you've got to assume that there are either things you can push to just virtual, things you can push to just self-care and self-service that's automated using machines, not people, things you can push to just virtual with lower paid, theoretically, less qualified people doing some of the interactions. You're seeing this a bit of mental health with use of coaching rather than psychiatrists. And then if you can, and this is the big question which no one can answer, is that if that constant care monitoring management stuff that the Livongos of the world and others have been doing, right, in diabetes, if that actually stops some people going to hospital and needing, more extreme care because they're kept under control, or there's fewer emergency room admissions or whatever, which we've heard a lot of people talk about over the years, I haven't seen a scale. If you believe all that, then the question is, do you end up with a small number of quote unquote platforms, and then he brings up, well, doesn't bring up, but he talks about, well, now you've got Android, with a few quote unquote vendors selling Android phones, and with the Android platform, you've got Apple with the iOS platform, which and obviously you could add in Amazon and for shopping and Google for search and advertising, whatever. But there's only a small number of really big players who are providing an incredible amount of services and sucking up an incredible amount of revenue for that in the tech world. So, I mean, his argument is that you end up with something like that because of the network effects in the care world. And I think that's a hell of a jump, but you could kind of see that you could see a path to getting there, because theoretically, and this was his argument, there is a network and a scale effect, whereas if I'm already doing this at mass scale, I can add more services on top. So if I'm doing it for diabetics, I can add it for people with heart disease, I can do mental health, and you're starting to see that slow consolidation amongst those digital health plays. But then the part where I say you have to make the leap is to believe that these organizations, let's make the guess that Amazon can, Amazon's just announced more mental health services for its employees. It's doing its own crossover. It's adding at-home testing, for COVID and stuff at home. It's got the thing where you can see it's adding a bunch of services, and it finally signed its first client, right, which we had 600 employees, and Teladoc stock went down like 20%. But you can imagine, one of these big platform plays doing these things, and if they do it better than it's done now, and they do it cheaper, theoretically, it could be back to 1994 in Southern California, where they are essentially the Bob Margolis 2.0 medical group of the future, which can manage people in all the ways they need to be managed, and buy off the hospital systems, by the physical care off the hospital systems when they need it for the expensive stuff. So I guess the question is that, in your mind, is that a non-starter? Is it gonna get somewhere? And I think the important thing is, are the people paying, who in the end, right, are either the taxpayer or the employer, some consumer, right, are they actually prepared to do what it takes to allow people to move to that kind of a system?
Yeah.
Also, there, where do you think we are? Are you complete? I mean, I know you're skeptical, but you think it's complete non-starter?
No, I don't think it's and I thought the article was interesting because it does speak to the key question of the scale effect, right? If you and particularly given this wave of funding we've seen in the last 12 months, with a lot of competing I mean, you know this space better than anyone on the planet, Matthew. I mean, all these things are lookalikes, right? I mean, they're
Right.
all point solutions that are barely differentiated from one another, you know, and so I think there's going to be a massive sorting out. And you've got some players now in the Teladoc Livongo thing, which I thought was interesting simply because you had two relatively mature offerings coming together, but it still is a revenue run rate relatively small.
Sure.
But you know, if you follow Vince's argument, and notwithstanding the pushback that Jeff and I and others have made about you're still going to deal with the physical world, there is a way to build, and it's one of the sort of 4 scenarios I've been sort of talking to people about, this healthcare partners 2.0 model, which is say, you know, do whatever you can virtually, but you need to still have a relationship with on the ground provider systems, you know, and that's why the Mayos of the world shouldn't be counted out on this as partner offerings at scale. But you know, for something to be a big deal in the future, it's got to start sometime. So you've got to see, I think, an exponential growth in enrollment and activity, you know, whether it be clinic visits or revenues of headcount and premium flowing through these enterprises at some stage pretty soon that they're meaningful. I mean, if you look at the startup de novo health plans like Oscar and Collective and all these other guys, it still seems to me a kind of a rounding error in terms of you know, the national marketplace. So if it's going to be a scale play, then scale matters. You know, and $1 billion or $2 billion in revenue, I think Vince was saying yesterday in terms of Teladoc's plan. You know, $2 billion revenue is like a small regional health system in Kansas.
So
I mean, seriously.
Yeah, no, it is. You're absolutely right. I mean, that to me, that's a big, you know. And there's a question as to whether there are some other questions in any one of these companies. Like, is Teladoc really selling to the incumbents? It's, you know, American Well seems to have gone down the path saying it's going to sell to the incumbents. It's not going to try and be a separate entity delivering care. We don't really know if Amazon is serious or not. I mean, yes, they've now sold something to somebody else. You know, 5 years ago, they weren't in healthcare at all. Now they've got a bunch of pieces. You can imagine them playing a long game and saying they're going to be there in 10, 15 years. I guess the two bigger questions for me is, one is, it's not like there wasn't really a set of incumbents in the tech business who did consumer tech, because there wasn't really consumer tech 20 years ago, 30 years ago. I mean, I remember you ran that, one of your non-healthcare moments, you ran the future of the postal service or something.
The future of global mail.
Global mail. But I'm sure that you and Greg Smith and some others came out and said that, I forget the number, but that by some date in the future, somewhere between 15 and 20% of goods and services will be automatically delivered to the house.
Yeah.
You didn't exactly say there will be a company called Amazon or a called Jeff Bezos who will dominate that platform, but you know, you said once you put enough technology in and the delivery piece in there, there's a lot more stuff that can be done with delivery than. And now, you know, look where we are. We're here, and if you look at the UK, it's even, you know, the growth of e-commerce and deliveries is increased even further, and that does a whole bunch of stuff. So I could see that there can be something in the future, but it really, to me, depends on on the buyers. It really depends on either the employers saying we're going to move people around, or the government saying we're okay, we're going down this path. And both of those are really tricky. So I'll give you one optimistic example. So Jonathan Bush did a thing in health, now is dropping his money around as the chairman of this thing called Firefly, which is a startup. It's a startup healthcare, it's a startup healthcare partners 2.0. It really is. It's got, they've got enough specialists who can attend a virtual visit to look after their currently young and healthy population. They've got their online mental health stuff. They've got the online primary care stuff. They've got, and they have a lot of contact. What really surprised me is the average, I think it's like one touch point a week between the average member and the team, the care team, one of the care teams, right? So there's a lot going on, and they've just raised a bunch of money. They're now going to go direct to employers to offer it to them. They're going to Florida. They're starting in Boston, but they're going down to Florida and Texas and wherever else, right? What he says is, and you buy it or not buy it, he says that the average, he thinks he can get down to small employers of below 1,000. And the average employer of that size is going to look at it, and he's going to be able to come in and say, I can name your cost in, half X that you're getting from the ASO plan, or you're getting from Blues, or you're getting from, whoever you're getting. And yes, your people will have to go onto my platform. They can't, go to see the regular local doctor, but it's going to be so compelling cost-wise that people are going to do it. We've heard stuff like this before. And that is one argument for moving around. And maybe it doesn't have to be 50%, maybe it can be 30% or 20%. But moving people around that way, and then moving people around from government programs in Medicare Advantage, I mean, it's a maybe, but I mean, is that enough? Or is it that, the cost of healthcare, although it's ridiculously high, is not enough to piss off any one individual employer or upset the government enough to actually really kind of push those changes on the people who are going to have to be moved around?
Yeah. Well, I think you hit the nail on the head. It's who's got the lives, and are they willing to, really force the issue in moving lives through these platforms, right? So, I mean, there are plausible ways that this could pan out. One is, through blocks of Medicare Advantage business, that Humana or whatever, builds a scale relationship with one of these players, and says, you are an exclusive, play, and we're going to do it. That's how we're going to do a business going forward, and that brings that block of lives. The problem is that Medicare Advantage is sold at the individual consumer level, so you got to bring the consumers along as well, right?
Right.
That's a tough. You're selling it one at a time, as the Clovers of the world are figuring out.
Finding out. I was on a call with Emily Evans. I don't know if you run into her. She's a Hedgeye, which is one of these sort of research funds, and I've been on her show once or twice. But she was talking about this, and actually, it's kind of true. And when I was doing this data back in, I was working with you in the mid-90s, Medicare risk was then was Medicare Advantage. Yeah, it went up to about, I mean, it was the mid 20% of Medicare recipients were Medicare risk at that time, but it was highly concentrated, right? It was like South Florida, Southern California, the Bay Area. And there are large areas of the country where it was zero or nowhere. And now it's at 35, 40%, but some of those markets, apparently Miami is at 80%. I didn't know that was the case, but I mean,
Western Pennsylvania is well over 50%. I mean, there are pockets where it's much higher. Yeah.
Right. So I'm wondering if you're there and you want to, I mean, do you have a way? Now you're saying I'm going to come in, I'm going to take market share of somebody else. It's the only way to grow. I can't just add new people. Is there a way that the Medicare Advantage plan, or this new direct contracting thing, which they're just trying to figure out? Is there a way that you can take that, you can put them on the platform, save all this money, and somehow kick that back to in some way enough to the patient, or make it reasonable why you would do this, where you could get someone to leave their current doctor, right? Which is essentially
I mean, that's the key, right? You've got to unhinge that relationship, and it takes whatever it takes to do that. That's why I think a lot of these guys are looking at self-insured employers, maybe mid-market size employers, or because then you get into the geography. When you deal with a large Fortune 50 company, they're spread out all over the place.
Right. Even more so now, right? Because people have been
totally
last year and a half been hiring all over the place.
Say I've got a South Florida solution, and just because you're South Florida headquartered doesn't mean anything. I mean, that's
right.
So that's why I've been trying to urge the Pacific Business Group over the years to what I call massify their firepower. Like, if they were all to say of their members, say, look, there's one plan and here's the vendor. They tried to do that with Definity a few years ago, and as the kind of what they called, Arnie Milstein was calling the breakthrough plan. But there's a lack of discipline there, because CEOs and CFOs get in the mix, and they can't agree, and my employees are different, and blah blah blah. So there have been issues about trying to sell it. But I mean, the short answer is, could this work? Yes, of course, and a lot will depend on execution and whether or not the incumbent purchaser, particularly, gets sufficiently pissed off. But the other thing that I keep coming back to, where I think is a fatal flaw of direct contracting on the commercial side, is, unlike Medicare Advantage, where the government pays for dead air, right? You know, using the radio metaphor,
Right.
like if I reduce utilization, I get to keep the money, right? That's why the profitability of Medicare Advantage is higher than self-insured employer business, because the employer won't pay for dead air. I mean, I've tried to negotiate, you know, I've literally had CEOs of health plans sitting in the room with benefit leaders of Fortune 50 companies trying to make a deal, saying, would you go direct? And the plans would, I mean, this is several years ago, the employers are going, the health systems are going, yeah, all I need is a 4% per year escalator in my revenue that I'm currently getting to cover my costs. And they're going like, wait a second. No, what we want is a 4% escalator that's going down, and the quality going up every year. And then so the conversation sort of stalls out at that point.
Well,
because it goes back to Bob Evans. Everyone's got income expectations, right?
Absolutely. Well, I mean, I'm also wondering, you know, what the, and we talked a bit about this before, but I'm also wondering about, we don't have, now healthcare's local, systems are local, even though the systems now are huge. You know, you said, you know, you've got these 8, 10, 12, 15, $20 billion revenue systems. Some of them have got spread over different states and different markets, but most of them are still relatively concentrated in the sort of the TV markets, right? This, you know, the Sutter plus Dignity plus Kaiser in Northern California, and the Providence plus whoever else up there in the Northwest. But it seems to me that you've got the option and the desire amongst some people at some of the bigger brand names to do something that, you know, looks like it should go national. So I thought it was pretty interesting this past week. I don't know if you run this company, Medically Home, which does hospital at home stuff. I had them on stage at Health 2.0 a while ago when they were just getting going. At that point, they just had the medical group in Boston, Atrius, is it Atrium or Atrius? Yeah. Atrius, the one that's not the North Carolina one, the other one. They just had them, and they just had like, you know, 5 patients had gone through the system, so they were super early on. But now they've been working with Kaiser and with Mayo, and they've been doing a lot of, in the pandemic, they've been doing, so what they basically do is they allow people to be admitted to home. So you don't actually ever go to the hospital if it's a medical admission. They put all the technology in the home. They put the oxygen stuff. They deliver all that stuff. They have nurses and people coming around. They equip the home, the lay caregiver, the husband or wife, or whatever, to do the minimal stuff. And they have a whole bunch of technology that is monitoring and watching and can do instant communication. They have a command center. Kaiser's now got a pretty big one, a command center, which, you know, looks at these, is basically doing 24/7 surveillance. And they don't have the cost of the big building. And apparently they can do this for 20-30% cheaper for those patients. Yeah. So then there's a question. What they said back then was that we think that we can go to, you know, these capitated medical groups and reduce their hospitalizations by 20-30% and, you know, reap the savings of their Medicare Advantage. What they then found was that during the pandemic, a lot of hospitals, in order to get started on to get their elective surgeries, which is sort of back up and away, wanted to get the COVID patients out of the hospital. So they put a lot of them, you know, a lot of these patients were sort of, you know, the mild COVID patients, and they were managing them outside, you know, at home where they already were quarantined, right? Mayo has, you know, so Mayo and Kaiser put 100 million between them into this company, and I'm starting to go, well, we've never really seen. I mean, Kaiser's in its different markets and whatever, but you've never really seen what you know you see in other businesses where you kind of get the brand. I'll use the Mayo brand or the Hopkins brand or whatever the brand is, and I will start doing my care wherever. Now I'm starting to think, well, okay, if I can ally with my local people in the local market that I need, and I'm now managing, you know, a lot of patients who were going to be in a hospital somewhere, but no longer need to be because I've figured this thing out using my local supply chain and my command center. It's in the bunker in Wisconsin, wherever the hell it is. Can you start seeing that as being the spread of back to Vince's piece, right? Is the platform, you know, a new version of Mayo with John Halamka running around building techie stuff, as opposed to, you know, the startups being invested in by by the folks at General Catalyst. I wonder if that's
that's a plausible platform creation too. Yeah, absolutely. No, I mean, that's why Vince's piece is an important thing. It's the question of execution on all of that. And I suspect that all of the above are going to be true. There's going to be hospital systems that try and do it to themselves and leverage off their existing brand. The Mayo example is a good one. You know, I think that's Providence's strategy. Certainly, you know, a lot of the people I interact with are the regional dominant health systems of, you know, 2 to 5 billion, own their market. I mean, I've been a fan of be big where you are, right? You know, and sort of, and they do end up having firepower with providers, and not in all cases, but in many cases have, you know, you look at John Muir in the Bay Area, or Synteg. I get mixed up between my Centuras and my Centegras.
Centura, the naming rights guys.
Yeah. Anyway, but you know, and market after market, you know, and I'm not talking about big brand names. I mean, Northeast Georgia, you know, so you'll find these systems that are 30, 40, 50, 60% market share, well run, integrated across the continuum of care, not always with a health plan necessarily, but you know, they're pretty well run shops, and they do well, and they have good margins, and you know, they're not actually a bad deal necessarily in all cases for their communities. But the point is that for those guys, there may be a partnership opportunity with a national platform player to give them that digital patina they need to tie some of the offerings together. And I think that's where it will be really interesting to see whether, you know, some of these bigger plays end up creating these hybrid arrangements where you've got virtual and actual care combined, because people do get sick, as what Jeff and I were saying,
right,
you know, yesterday, and you're still going to need surgery, you're still going to need, you know, anesthesiologists and all that good stuff, and then they can't just be virtualized for everything. So it's how you integrate with that I think is a key. And to go back to your mail metaphor, I mean, that's what we found in that study was, in the long run, you know, messaging will be digital, right? Except for parcels. And that was kind of the big aha we had all these global postal services around the world, and Pitney Bowes was kind of our anchor client. But we actually did, I think, a lot of good work that measured the decline of messaging and what the factors were in that. And the US way behind. You know, I mean, they've been doing cell phone payment in Sweden for 20 years, you know, or more.
And a bunch of places in Africa, they never got to the mail.
Right, exactly.
They're still on your phone. Anyway.
Exactly.
Yeah, I think that's interesting. So last couple of minutes, let's switch. So what do you think about, you know, we started before we turned the camera off talking about this. You know, we've got this sort of bizarre political moment going on in the US and going around the world, but a lot of this is about attempts of Biden, and what you mentioned, you know, we saw Biden driving around the new electric Ford truck. You know, can we get a new modern thing built in America by union labor to the people, you know, in the heartland who drive those things around? You know, there was some politics. I can't remember who it was, but someone a couple of years back saying, you know, what is it that the Democrats have got to give to a guy who drives a pickup truck, right? Sort of the Republican, and I see that coming. The other thing that was promised in the campaign, although not that loudly, was the public option and, you know, Medicaid expansion and all this other kind of stuff, which hasn't really got to the top of the political agenda. Do you think that if you go back to what we were saying right at the start of this hour, the US never really figured out how to deal with the poorer people, you know, the working poor and others who are kind of left out of it? It's still not great. This past, you know, this week we've had the story from on CNN of basically of community health systems, right, for-profit hospital system in multiple states suing the bejesus out of, you know, a bunch of poor people who couldn't afford it,
right,
and making their lives miserable. Do you see, and they're not a lot of the money, but some of the money from the digital health sort of boom has gone to the people like Cityblock and others who are trying to figure out, is there a specialist way that we can build a system for minorities, poorer people, the frail elderly, et cetera, et cetera? You know, can we do that? Do you see anything optimistic in that, or do you think this is just an American feature that will never get to be like Finland, and we just won't have the sort of comprehensive social coverage that some of us might like?
Well, I'd say two things. One, elections matter, right? I mean, if we end up with a Trump administration again, where there's a reversal and a Republican Senate, I think they will roll back much of the progressive stuff that Biden has done, and will just be 4 trillion in the pokey, with an unfair system. I'm actually encouraged. I think that some of the actions have been taken, that there's thoughtful innovation. I mean, City Block and others, I think, are, the whole social determinants conversation is still moving along, and so I have some optimism about that. It comes down to income inequality, quite honestly, and then compounded by racism,
Sure.
as the key driver. And we were talking before we came on about sort of deindustrialization, and I think that's a very hard thing to undo. I mean, Biden can drive the truck, but supply chains are global and will eventually, if you can make stuff cheaper elsewhere, absent sort of tariffs and market interference, you're going to end up paying more for the product if you make it here. And the real question is, how do you sustain life for people who are not going to be algorithm creators or blockchain managers, and that's a very tough social and educational problem that I think it's hard to solve for. But you can certainly do it with a lot more compassion than maybe we've done in the past. But I think there's the wrenching transformation to a post-industrial economy, and I think if we can create sort of real shovel-ready projects. I mean, Obama's idea of shovel-ready was, giving a bunch of money to Epic to do electronic health records. But get some real shovels going, or bulldozers probably. We might be a bit better off. But no, I think given the right political environment, we can be a bit kinder and gentler. But I think swimming against globalization is a hard deal.
Do you think that I mean, clearly we're going to have more government involvement now than philosophically, what forgetting how it was actually spent philosophically we had over the last 30 years, we're going to have more government involvement going forward, because you haven't actually seen aggressive pushback against, you see theatrical pushback. You haven't seen really aggressive pushback against government involvement and government spending from the Republicans. This is an ideological fight about something else, right? But I mean, if you accept that there will be more, and you accept that perhaps you could do things like get to renewable energy and get everyone an electric car and get everyone have mass charging stations across the country, and all the kind of the woo-woo stuff, about how we're going to get off oil and get onto wind and solar and stuff, which I believe. I mean, the prices are going that way anyway. It will actually happen pretty quickly. But I mean, again, you've got to take that, you've got to distribute the implementation of it so that it gets done more fairly, and not doesn't just make the top 0.1% even richer because they own Amazon stock or Google stock or whatever. And then you've got to go to the next part, which is can you actually good morning. my daughter's come by to something. Can you come back in 2 minutes? 2 minutes.
I need to charge this.
Okay, I'll charge it for you.
Got it.
Later. The beauties of doing live broadcasting on podcasts when you have 10-year-olds who need their iPads charged. But my point is that you can imagine distributing the money better, but at some point you've got to say, all right, we're going to provide for people who have quote unquote less, who don't have the sort of on building the algorithms and doing the more productive stuff and don't have the college education. Yeah, there's a lot of long social things we can do to fix that. But we've got to provide better services, including healthcare services for those people. And that's got to come from taxing the richer people. And when we have, as I said, you have a Trump administration that the guys at 55% or whatever the number is in the running for the next primary, the next Democrat, the next Republican primary, you know, who knows? They may win the Senate, they may win the House, and this stuff may all get kicked back. So it's tenuous if you ask me. I don't know.
Yeah, no, I agree. But the other thing just came to mind was, as you were saying, you know, about where we are fiscally, that caught my attention the last week is just the California government budget surplus, right? I mean, we are massively in surplus, largely because of the IPO boom and the capital gains that took place with the rebound of the stock market, to the point of embarrassment. You know, it's like over the 2 fiscal years, something like a $70 billion surplus. So, you know, part of the conversation that's going on at the state level is, you know, where does that money go? And I just see that, you know, if I was a conservative Republican, I'd be furious. I mean, Mitt Romney was moved to anger about, why are we giving money to California? And he's got a point, you know. I mean, I was very worried about the opposite.
Right.
A year ago, you know, we all, when the market was down, you know, back in March of 2020, you know, and things were looking dire for the states, but it's completely reversed. And California is an outlier in that, but the fiscal situation eventually matters. That's, I guess, what I'm
and the other way is that you know, do you end up, you know, we talk about, you know, corporate capital gains and corporate taxes, and you end up sort of actually figuring a way to tax the people who've done so well out of this to pay for the other stuff. That's one thing, and Biden's clearly starting to go on that path, and they're starting to talk about international treaties, so you can't just automatically move all your money to Holland or whatever the hell you are if you're Facebook or Tesla or whoever's doing that kind of stuff, or Google. So, you know, I think that's one thing. The other thing to me is you've got to figure out a way that we distribute, and maybe it will happen now because of people moving out of the cities, because of, you know, working remotely. You've got to figure out a way you've got to distribute the infrastructure more broadly, and that includes health, but obviously includes, you know, if you drive across the country, there are large pockets of the place where there's no cell phone signal, there's no you know, there's no broadband. We talk a good game about doing that, but we actually don't do anything about it. Whereas I view, you know, the future of healthcare is we can fix it by doing that, and all the stuff we talked about, all the platforms, you know, they've got to work. But we're talking about there are huge parts of America where you can't get near a doctor, and the local hospital closed, and you know, we've got to figure out how do you deliver that service to where people are, or else you're going to have increased, you know, decline in those industrial. We're already getting it, right, where people, you know, it's like the nomad land thing, where the plant's shut and they wanted to get in trucks and drive around and become Amazon workers. We've kind of had that in America historically, right? Grapes and broth and all the rest of it. But at some point, we've got to figure out how to make that distribution work better. And it's lip service now, but we'll see.
Yeah, no, and I would just say, you know, having been a student of the kind of post-industrial economy now for nearly 50 years, that you know, the post-industrial economy, one of its hallmarks of a knowledge economy is you know, a rising inequality between manual labor and knowledge work, and the gains from that, and as self-evident by, you know, what we've seen in income, even exacerbated through COVID. So, you know, the response has to be some kind of redistributive economic policy and investment in the least fortunate folk and places, you know, very directly, to your point. So I agree with that, and that's maybe the lesson. You know, from 50 years of screwing around with this stuff.
Yeah, just because we agree doesn't mean it's going to happen. All right. Well, look, we've done an hour of the THCB Gang, a very small gang. This week, just me and Ian chatting. Ian, it's been really fabulous getting deep in with you. Really want to thank you for coming on the gang. Thanks for all the help you've given me over the years, and whether or not I was supposed to take work off your plate or build out the team or whatever it was. Really great to hear your thoughts on that, and your thoughts on working in healthcare in America for quite some time now. We won't say exactly how long. Yeah. So I've been talking with Ian Morrison at Circa on Twitter, and one of the two great living futurists, because we all say nice things about Jeffrey this guy in healthcare. And we'll be back. This is the end of THCB Gang for the 20th. We'll be back with probably a larger gang, presumably back to full strength, hopefully, next Thursday at 1:00 Pacific, 4 p.m. Eastern. This is Matthew Holt, Baltic Boy from the Healthcare Blog, signing off, saying thanks for watching.